attention.
Many thanks, Prof Yasser Musbah, for this nice presentation. The next speaker, Wessam Fathey, he will talk about transvenous embolization of brain arteriovenous malformation, up-to-date meta-analysis.
Good evening, ladies and gentlemen. First of all, I would like to thank you, Professor Dr. مسعد سليمان لدعوتي السنوية لمشاركة أساتذتي وزملائي في جراحة الأوعية الدموية على مستوى الجمهورية. I'm going to talk in the first few minutes about transvenous embolization of brain AVM. As we know, brain AVM usually presented by brain hemorrhage with annual risk of bleeding about 2% to 4%. Treatment of brain AVM is still challenging due to variable pathological pattern, different location, and unpredictable hemodynamics. There are three options for treatment of brain AVM as we know. The first one is microsurgery, radiosurgery, and endovascular embolization. Regarding microsurgery for brain AVM, it achieved definitive treatment, but it carrying risk of significant morbidity rate with permanent post-operative deficit. Regarding radiosurgery, brain AVM can be treated by radiosurgery, but complete obliteration requiring extended period of time. In addition, radiation can cause tissue injury of the surrounding brain tissue with subsequent morbidity. Endovascular embolization of brain AVM can be used as palliative treatment or in combination with both radiosurgery and radiosurgery. With advance in the technique and the material, experts have attempted to achieve curative embolization and improve neurological outcome. But endovascular embolization of brain AVM is still difficult due to different challenges. The first one is navigation in multiple small feeder and achieving deep and complete onyx embolization. Furthermore, arterial occlusion without obliteration of the venous outlet of the brain AVM can one of the risk factor of brain AVM recurrence. There are two methods of endovascular embolization. The traditional method is transarterial embolization, and the newest one is transvenous embolization. Transarterial embolization of the brain AVM are usually used to reduce the size of the large AVM, enhance surgical safety, and make AVM amenable to radiosurgery. This technique can achieve curative rate exceeding 50%. But transarterial embolization of the AVM, of brain AVM, is still challenging in many situations, like plexiform nature of the AVM, distant location of the nidus, presence of a small tertiary arterial feeder to access. That's why transvenous embolization of the AVM becomes a novel therapy in the last few years for treating of some cases of AVM with achieving rate of curative treatment exceeding 30%. Transvenous embolization of the AVM is a retrograde axis in which we use systemic and local hypotension to control intranidal pressure. This transvenous embolization technique was first discovered for treatment of transverse sigmoid dual AV fistula, vein of Galen malformation, and carotid cavernous fistula. Masood and his colleague in 1999 was the first one to create a trench technique which described as transvenous retrograde nidus sclerotherapy under controlled hypotension. From this time, transvenous embolization of the AVM was increasingly utilized. As we see in this picture on the left side, we can see using مش شغال. Okay. مش شغال. mouse. Okay, I'm sorry. As we see in this picture, we are deploying balloon in the posterior cerebral artery to decrease venous outflow. Okay. This way? Okay, thank you. By deploying balloon in the arterial feeder in the posterior cerebral artery to decrease venous outflow, and in the right side we can see by deploying 8 French guiding catheter in the jugular vein with distant access catheter in the sigmoid sinus and the distal microcatheter close to the nidus. By this way we are decreasing the venous outflow and we can do complete obliteration of the EVM. This is our study meta-analysis which was published in 2022 regarding transvenous embolization of brain arteriovenous malformation. This current meta-analysis aims to assess the access and the complication rate of transvenous embolization, and it determines the efficacy and safety of transvenous embolization of the EVM. This current meta-analysis revealed that the transvenous embolization of the EVM had 93% immediate endovascular total occlusion rate with 90% good functional outcome and 10% overall technical complication. This table summarizes the EVM characterization and the previous treatment. As we see in this table, previous session of transarterial embolization were reported in 44 patients. That means this number highlights the complementary role of transarterial embolization to transvenous embolization. Similarly, the transvenous approach has been reported to aid the transarterial embolization of brain EVM. This is the technical aspect of transvenous embolization. As we see, this is 7 studies concluded that 5 studies used transjugular venous approach, 1 study used transfemoral approach, and 1 study can't decide which approach. In all studies, both detachable and detachable microcatheter were used, like Sonic microcatheter, Apollo, and Marathon microcatheter. In this review study, transvenous embolization was achieved with the aid of other endovascular technique, like, as we see, the transarterial and the transvenous combined approach was performed in 48 patients. Arterial inflow control during the transvenous embolization using a balloon or polymer embolization or modified pressure cooker technique was utilized in 35 patients. Venous balloon assisting navigation was used in 11 patients. Selection for cases of transvenous embolization depending on the angio-architecture and characteristic of the brain EVM. Most brain EVM included in this study were small EVM with nidal size less than 3 centimeter and had single draining vein, had deep venous bridge. That's why large brain EVM mostly have large draining vein which are more challenging to occlude without a reflux. The presence of multiple venous outflow is an obstacle for the retrograde diffusion of embolizing liquid material to all the shunt. Brain EVM with deep venous draining vein are much easier to access than the cortical vein due to their straightforward course and relatively lesser angulation. Technical complication was recorded in this study. The first complication was cerebral infarction, and the second complication was intracerebral hematoma. Subacute hemorrhage was recorded in 4 patients, cerebral hematoma and intravesical extension in 5 patients, sole intravesical hemorrhage in 6 patients, and cerebral hematoma in 3 patients. Among the aforementioned patients, 50% has good functional outcome. This table summarizes the EVM characterization associated with intracerebral hematoma and time of intracerebral occurrence. As we see, intracerebral hematoma was recorded in about 19 patients. In most of these cases, there are different explanations for this intracerebral hematoma other than microcatheter perforation. One of this explanation is a large nidus is more difficult to achieve complete embolization rather than a small nidus. The second explanation for this intracerebral hematoma is that multiple draining vein associated with retrograde nidus embolization through one of vein may cause undesirable premature occlusion of the another draining vein, leading to increased intracranial pressure with subsequent intracerebral hematoma. The third explanation is the delayed post-operative intracerebral hematoma edema and hemorrhage can occur secondary to impaired cerebral vascularity. In conclusion, transvenous embolization for brain AVM was generally safe and effective in certain selected patients and in experienced high volume center. However, randomized trial with longer follow-up duration are needed to consolidate this finding. Also, the role of transarterial approach prior to transvenous embolization or combined transvenous embolization with transarterial embolization can't be separated. More studies regarding the complementary role of transarterial to transvenous as a definite endovascular treatment for brain AVM need to be conducted. Thank you for your attention.
Thank you, Dr.